your seats, continue eating your lunch, but we have to move on, or we never, according to the boss, we never finish the program. The first speaker will be a state-of-the-art lecture on repairing the aortic valve with Laurent de Kerchove. Laurent.
It's a great honor to be here, and I would like first to thank, of course, Maral and all the organization committee for the pleasure to be here. I'm not a giant. I'm just a good student, so it's really a privilege for me to be here. So I have to disclose that I start my training in cardiac surgery. Now it's a bit long time ago, with a residency in Clinique Universitaire Saint-Luc, where I was very lucky to be because I was trained by Dr. El Khoury, and I literally fall in love with valve repair. And I've never been a fellow in Toronto, but a little bit feel like I was. Because JBrain has been so much influenced by you, Tyrone, that his entire career was on basis of what he has learned with you. So
good student.
I think JBrain was born 2 times. One in Lebanon in 1958, and the second time in Toronto in 1995. So I was trained to do the reimplantation technique a little bit the El Khoury's way, and principally we have pushed the indication for the David operation so far that it did become something else than just a root replacement for an aneurysm. It became a real annuloplasty technique to treat aortic insufficiency. And that's why now when we schedule a patient for AI in our department, the operation is called Plasty Aortic Tirone David. That's it. So let's remind us that the patient referred for AI are very young, especially the bicuspid one. They have, in average, 45 years old. The tricuspid may be a little bit older, but if you look in the series where they have been repaired, they have an average 10 years more than the bicuspid valve. 40% will be bicuspid, 60 tri-leaflets. And this is very important in the lifetime management of their valvular disease, because being young, I mean, they have to be rid of prosthetic valve-related complication, pacemaker, and anticoagulant. That's why we put a lot of our efforts in repairing those valves. Now, looking at the guidelines, I won't speak about the aortic guidelines. I mean, only if you want to do early root replacement surgery, be sure that you preserve the valve. Otherwise, if you plan to replace it, get more stick to the class 1 indication. Regarding AI, the situation is a bit different in my opinion, because we know that the trigger of class 1, they are related with a certain penalty in the outcome. If a patient goes for surgery when he's symptomatic, or his ejection fraction is already decreased, or if the ventricle is severely dilated, there is an outcome penalty to operate on him at this time. That's why in the latest guidelines, this class 2 criteria have been set, which is a little bit earlier than the class 1 in terms of ventricular dilatation and left ventricular function. And in fact, if you look at the outcome, the survival principally, of patients having class 2 triggers, the survival is better than the patient having class 1. And interestingly, if you want to repair the valve, you will have a better outcome if the patient has a class 2 guidelines criteria in terms of ventricular dilatation than if he had a more severe dilatation. So, in other words, a patient with severe AI, it's better if you go early for survival and to have the best chance to produce a long-standing valve reparation. So this is the history of aortic valve repair, and I may have missed some of the techniques that have been described by some that I wouldn't have think about. We may say that there are a very important turning point in the journey of aortic valve repair, and this is the description, the invention of the valve sparing procedure. Because invention of those procedures increased the field of valve sparing and repair a lot. Before that, any root dilatation was just replaced, where we know now that it's in most of those patients that the valve is repairable. Now, next to the technique, which are of course very important, much more have been learned. And out of the global knowledge, there were fundamental concepts that were described, and also classification and standardization, sometimes from our own failures. One basic concept is that if the patient has an annulus dilatation, your repair may not last very long if you left this annulus dilatation untreated. And most of patients with aortic insufficiency, we know that now very well, it has been established, they have a large annulus, annuloectasia, and it is even more pronounced in patients with bicuspid valve insufficiency. That's why the remodeling technique has been proposed by Tirone David first with an annuloplasty. And then different types of annuloplasty have been proposed. And the reimplantation also has evolved over time in the optic of improving leaflet dynamics, coronary perfusion, and the sinus of Valsalva were attempted to be created during the reimplantation procedure. Whether this modification already has a clinical impact on the durability is not very well known or not very clear, and probably that graft configuration may be perfectible to really have a clinical impact of this neosinus concept. It seems that whatever the graft you use, the most important is to make your valve sparing correctly in terms of durability. And Tirone David has shown us very strongly how it is important to place this graft at the subvalvular level. And it is the same for an external ring if you use this technique. And for doing that correctly, you need, it was stressed out by Tirone yesterday himself, you need to make deep root dissection to reach on the outside aspect of the root the level of what we call the basal ring, which is the plane passing through the nadirs. An external root dissection isn't a dangerous maneuver. There is a plane which is well known by surgeons doing Ross operation to detach the pulmonary root from the muscular septum. And this plane is sometimes filled with some fat and Sometimes there are less fat, but you can detach the muscular fibers from the right ventricular outflow tract and from the septum. And this is how we have developed that in Brussels in a way that we were at the beginning criticized because it looks dangerous, but it has become our systematic way of doing a David operation. And we have very rarely small hole in the right ventricular outflow tract, maybe at the level of the right, close to the right non-commissure, but this is very easily closed with a stitch. And this is how you can be sure that the graft can reach the basal ring level and it's a proper position. And when we resuspend the valve within a well-positioned graft, you barely have no prolapse at the end. Now, another fundamental concept was by my mentor, the concept of functional, seeing the aortic valve as a functional unit. And from that, Tirone was capable to propose this well-known classification. I will not go into the detail on it, but this is so known by the community now that I think it don't need to be detailed, but just I want to say that some of the technique, of course, described at the early time have been modified. This classification is really based on the same concept as the mitral valve classification, where the mechanism of aortic insufficiency need to be understood to be capable to treat the lesion and correct the dysfunction. Now, from this classification come the idea of functional aortic annulus. The functional aortic annulus is the VAG, the leaflet insertion, and the sinotubular junction is the native stent of the aortic valve. Any dilatation of those segments may induce AI. And if you want to support or reestablish a normal dimension, you have to play on those different parts of the aortic valve, the functional aortic annulus. And it is with this concept that we have pushed the indication of valve sparing surgery, because it's the only technique that will have a role on all of those parts of the functional aortic annulus. So we develop this functional aortic annuloplasty concept using the reimplantation to treat bicuspid valve insufficiency and also insufficiency in three-leaflet aortic valve with moderate root dilatation. Not only the functional aortic annulus matter, but also the leaflet configuration. And more 20 years ago, we have already had clearly the information that having a low coaptation within a valve sparing was a very poor configuration for long-term durability. And from our group, we have added some details about the quantification of coaptation, level, and length to have a durable result. And Professor Schaefer's bring even more detail about the quantification of what would be a good coaptation. And the effective height concept came where the 9 millimeter we all have in head is now well established as being what could be the best coaptation level after aortic valve repair. And also the quantity of tissue matter, and the geometric height or the cusp height, which was a terminology used by Dr. David well before, of course matter a lot when you want to spare the valve. And when it is less than 16, it's probably better if you are not too much experimented to replace the valve, 16 millimeter. Now, when you do a valve sparing in a root dilatation, you may chronic root dilatation. You may expect to have, you may expect to have a leaflet that is not normal. The leaflet is overstretched chronically and it is deformed. It is well showed in the literature that the free margin is elongated. The geometric height may increase a little bit, but not as much as the free margin. A normal free margin length is about 34 millimeter. In those patients in whom you do a valve sparing, it's 1 centimeter longer in average, 44 millimeter. So when you do a David operation, by reducing the diameter of the root, doing a functional aortic annuloplasty of all different levels, you will automatically reduce the level of the free margin because you reduce the diameter of an elongated free margin. Therefore, it's very important to measure at the end what is your effective height to resuspend correctly the valve inside the graft, and if necessary, do application. And not all the free margin can have the same length because of the asymmetry of the dilatation, and that's why we end up sometimes with a prolapse, whether you haven't noticed that at the beginning. So right cusp prolapse is the most frequently observed after valve sparing reimplantation, and we will be more on that later in another topic talks. So standardization, of course, is important, and we have to give credits to Emmanuel, who has spent a lot of energy to teach people to make things in a very standardized manner, to learn and to have reproducible results. Now, there are not only the 3-leaflet normal valve, there are congenital valves, which have a totally different geometry of the normal one. And here again, there is a clear definition of what is a tri-leaflet, a B-leaflet, and a unicuspid aortic valve. There was in the past classification that made confusion between bicuspid and unicuspid. Now, I think it has been, thanks to the work of people repairing valve, it has been made very clear in the definitions. The unicuspid valve are amenable to repair, but the long-term outcome is not very good because you replace part of the valve with a pericardial patch. It has been shown that it is good to be used in infants to delay eventually valve replacement or Ross operation, but in the adult, it's probably better to do a Ross operation in those patients because unicuspid valve repair doesn't last more than 10 years in average. Now, regarding bicuspid valve, which is one of the biggest indication for aortic valve repair nowadays, up to 40% in your practice if you developed this repair expertise. Also, the geometry of the bicuspid valve can be modified, and this can be very interesting in the repair because it will avoid the pericardial patch extension if you modify the geometry of the valve. No patch, 2 mobile leaflets at the end. That is the objective for a long and durable repair. These learnings about geometry make different teams to look at bicuspid valve in some different way, and we finally noticed that there is a spectrum where clusters can be identified, and those clusters may help people to repair the valve with techniques and with degree of difficulties that vary across the spectrum. A symmetric one will be the easier to repair. An asymmetric one is a bit more complex, and you have to change the geometry. And then the very asymmetric is maybe the one that is more difficult to repair, and you have to keep that for your more expert level. Now, maybe this classification may also predict the outcome, but more study needs to be done about that with the different techniques that are used nowadays. Now, what about the long-term outcome? Now, I'm sure now, Tirone, this study is outdated because you have the 30-year results that will for sure astonish us as usual. But let me just remind you how good can be the results of this surgery in the hand of an expert with the highly selected patient. It's just one of the best procedure cardiac surgery has developed in history. Now, in our experience, we have pushed, I remind you the fact that reimplantation is used also to treat pure AI. And this is our latest publication regarding 3 different indications for valve sparing: dilatation without AI, dilatation with AI, and pure AI. And you see that the results at 12 years are very equivalent in the 3 groups, and no difference between bileaflet and trileaflet valve. Now, the remodeling guys are doing quite well also, especially Tirone showed us this morning that remodeling in patients with small annulus can work very well. Look, the experience, one of the greatest cohort of remodeling by Schaeffer's, half of the patient didn't have annuloplasty, and there is no difference. Of course, there is a selection. So the annulus of those 2 groups may not be the same, but it's a proof that it can last a very long time without an annuloplasty in a well-selected patient. And with an annuloplasty external ring, the results are also very good. Most of the group who've developed a lot the technique of bicuspid valve repair with this anatomical concept of modifying the geometry, stabilizing the functional aortic annulus with circumferential annuloplasty, were able to improve significantly the results of bicuspid aortic valve repair in regards to their initial experience. Now let's come to the Marfan patient with connective tissue disorder. It has been highlighted this morning, and it's a good introduction to what I will show now. Remodeling and reimplantation can work for a long time, 10 years. But then after 10 years, there is this very, I would say, strong signal that the remodeling technique may not be adapted for those patients with very weak tissue. And a fundamental concept of remodeling is to place the graft, make your running suture very close to the leaflet insertion. And I want to show this movie. We also record all our intervention, and we keep it stored so we were capable to take it out to show how we did at this time. And this is Jirin doing a remodeling, learned from you, Tirone, after he came back from Toronto. And look how close the stitches are from the leaflet insertion. Now, we are now 25 years down the road, and this is the common observation we found on patients with failed remodeling in Marfan patient, or Lois Dietz. One patient after 10 years had a root of 55 millimeter, moderate central AI. The other patient, they waited until 25 years to be reoperated. And look how the roots dilated. They look like each other's, like they were never operated. Interestingly, they didn't dissect or rupture, but they had severe regurgitation, severe annulus dilatation. And the common findings is a disjunction between the graft and the valve. So the suture turned out chronically, and you see that there is no aortic wall anymore. So the entire root is a pseudo-aneurysm. We could make a reimplantation in those 4 cases because the valve was very good. Now, adding an annuloplasty to the remodeling can improve the results, and I believe they will be improved. But remember, you have to wait the second decade to see the patient coming back for surgery. So maybe it's not time to conclude, but we have to look at that very closely. Repair versus replacement. You have seen the loss of survival with eventually valve replacement because of the burden of the valve-related complication in prosthesis after prosthesis valve replacement. The survival after repair have been shown to be more close to the age and sex matched population, and the few studies that have retrospectively, but in a propensity matched fashion, compared replacement and repair, or it was more in the context of valve sparing procedure, they all show a survival benefit for the valve sparing. The group of Toronto, Maral published that 10 years ago, the Caviar trial from Emmanuel Lansac, and also the group from Emory. More reoperation in bioprosthesis, and compared to mechanical valve sparing is doing very well. And more bleedings with the mechanical valve, we have seen that. The future of aortic valve repair, can we still make progress? I believe yes. There are new imaging technology that is fantastic to planning surgery. We can measure everything. And measuring everything before the surgery can help young surgeons to have appropriate guidance for the surgery and to plan the surgery in a better way. There are tools coming to measure the free margin, to measure the aortic root, to size the graft, and eventually to control your repair procedure with an objective visualization of the valve under pressure. So to conclude, after 60 years, aortic valve repair has reached maturity in mitral valve repair. In severe AI, early surgery before class 1 triggers optimize survival and probability to perform durable repair. Aortic valve repair should be the first-line treatment in young patients with root aneurysm or severe aortic insufficiency if the valve presents appropriate characteristics to be preserved. Strict patient selection and surgeon experience and guidance, if you are in your learning phase, are the cornerstone for very long-term durability after repair. Thank you very much for your attention, and thank you, Tirone, for having made my professional life so exciting.
Thank you. It was wonderful. This is going to be followed by